So good evening to everyone. Thank you for joining me tonight on again a webinar from the Pulvertaft Institute. First of all, a big thanks to the organizing committee, So and Carlos in particular tonight, for having me again for another opportunity to do a webinar. It's a pleasure and an honor to do this again. And tonight I would like to discuss the guidelines in the management of fractures of phalanges and metacarpals. And this is based on the somewhat recently introduced Dutch guideline. I was a member of the guideline committee, but it is impossible to do this presentation without the effort of my fellow guideline contributors from all specialties, surgery, orthopedics, and plastic surgery. So thanks to them as well for this presentation. I would like to do it somewhat different tonight. This is a very clinical exposition tonight because it's somewhat late. So I think this is a very nice way to do this guideline. I'm not getting in a lot of detail with the literature that is used and this guideline was based on, but I would like to refer to the Dutch guideline, which is online, and all 34 high quality studies that were used for this guideline can be found on this database. So thanks again. Without any more introduction, I'd like to start. I have no disclosures. So we'll be discussing articular, non-articular phalanx and metacarpal fractures tonight, and especially, which is the highlight, the indication for operative treatment of these, because that is always the question. I will go into fixation technique, not so much into surgical approach. Again, there are very good books and very good websites for that, especially the AO. I could go into detail if there's questions in the Q&A, but it's not the content I would discuss tonight. And especially some advantages and drawbacks of different techniques. And as I told you, this is based on the Dutch National Guideline on Treatment of Hand Fractures. So as an introduction, fractures of the phalanges and metacarpals, maybe we do not realize this, but are the most common upper extremity fractures you will see in the emergency department. So 0.2 to 3% of all ER visits, not just for the traumatology department, but for all ER visits. It is because there is a fracture of the phalanges or metacarpals. And however, these are not life-threatening injuries. They do have a very high societal impact and do present with high total healthcare costs, mainly due to the fact that the majority of these do present in a very young age, between 11 and 45 years. And this is the age group that is professionally active. So a problem there will lead to long unemployment and a lot of problems. And as a result, the indirect and total healthcare costs are quite high. So a beneficial functional outcome is demanded, and this needs correct length, correct alignment, and correct rotation. So these factors are extremely important to make sure that early mobilization can be done, and joint mobility, tendon gliding, and prevention of adhesions is key there. So these parameters do tell you whether surgery is indicated or not. So when we discuss operative treatment of hand fractures, or the treatment of hand fractures anyway, there are a few historical figures we cannot disregard when we are talking about this topic. And the first is Dr. Albin Lambot. He's a famous Belgian surgeon from Antwerp. He was not only a surgeon, he was also a violin maker, which is quite convenient because in a lot of ways there are similarities between those two professions, I think. But Lambot was the first one ever to use purpose-guided materials. So he did not use the materials that were used before, like piano strings or carpenter nails. No, he used solely for purpose of surgery. He used materials that were specially developed for that. And as a result, in 1907, he was the first ever to operate a tibia fracture using an external fixator. And 2 years later, he was the first surgeon ever worldwide to operate a hand fracture. So he's the pioneer in hand surgery, actually, who first operated a hand fracture, which was a metacarpal fracture in the early 20th century. And obviously Martin Kirchner is a very important historical figure as well, because his invention in 1909 has become a very important tool for a lot of hand surgeons when treating hand fractures. So these two historical figures are of essence when we discuss hand fracture treatment. So there's been a lot of change the last 3 decades, and I would like to emphasize these changes because they are very important. First of all, there is a much more profound understanding of biomechanical principles in internal fixation. mainly due to the fact that biomechanical studies are increasing in quality and number. So this is the underlying mechanism for a lot of development. We use a very low threshold for advanced imaging nowadays, especially for periarticular fractures and especially perioperatively. And we have improved surgical tools and material. We have anatomical plates 0.6 millimeter thin with variable angle locking for various indications. So our materials do help us a lot with the change of our practice. And two other things I would like to emphasize, which has become obvious in the Netherlands, but most certainly in the rest of Europe, which is specialization and hand specialization, hand surgery, leading to improved quality in care, mainly due to the fact that we can treat larger numbers by a select group of hand surgeons who are dedicated to this profession. And don't forget the role and the importance of multidisciplinary treatment. So there's a very important integral role for the hand therapist in treatment of hand fractures. And as a result, they are a very important part of the team, especially our team, but a lot of teams. So a multidisciplinary approach is a very important thing. So Alfred Swanson already told us that hand fractures can be complicated by deformity from no treatment due to the pull of the intrinsic and extrinsic hand muscles that do displace the fracture, stiffness from overtreatment, especially from scarring and adhesion formation, and deformity and stiffness from poor treatment. Now, poor treatment is a big problem. This is not per se a very poor treated fracture, because this was from my own institute. But what I would like to say is that this is, I think, fairly well operated. But an early beneficial functional outcome is counteracted or opposed by unnecessary prolonged immobilization. And I think this is also a sign of disappointing treatment. So poor treatment, I'm not sure whether you should call it like that, but we see this on a frequent basis, even in our own institute. So you shouldn't do this. So early functional treatment for every hand fracture as early as possible is extremely important to make sure that a beneficial functional outcome is the result, and joint mobility and tendon gliding can be done. Another important factor is adequate patient selection and appropriate treatment. For appropriate treatment and fracture selection, we have our guidelines. This is our Dutch guideline, which we adhere to in the Netherlands and a lot of hospitals. But patient selection is another very important thing. If you look at this fracture, for instance, this is a metacarpal neck fracture with a significant dislocation, and you might think that this is a nice indication for a percutaneous approach after closed reduction. But you need a cooperative and a compliant patient for this. And usually these are the patients that present with these injuries, and you can imagine that this is not a compliant and not a cooperative patient. So if you do this kind of surgery in these kind of patients, they may not be, this may not have a positive influence on these kind of patients. So patient selection is also very crucial. So you should choose wisely which procedures are suited for which patients. So let's start with the beginning. Obviously, history taken in physical examination. A few words on that. The trauma mechanism is extremely important, because if the patient tells you this is the trauma mechanism, but this is actually the wound you see, then you must be sure that the trauma mechanism you see there on the left is not actually the trauma mechanism that is presented by a patient like this, because this is a fight bite. So this is a completely different trauma mechanism that opposes you with a lot of problems. There's not only probably a fracture, but there's also a tendon laceration, even a joint laceration, and a high risk for infection, because these kind of injuries are usually the result of the encounter with the tooth of another person. So this can be a big problem. Timing and location of injury is obviously very important. This is a completely different location of injury, and the right one has completely different results if you treat him in the same way. Specific complaints, daily activities, not only professional but hobbies as well, are very important also. Hand dominance, I don't need to mention that, of course. So physical examination, initially without anesthesia, because you don't want to influence your outcome by giving anesthesia from your physical examination. Be aware of malalignment and do not reduce fractures or dislocations too early without any additional imaging. So rotational deformity is very important. Look for that, obviously, and neurological disorder can be very difficult and subtle, but you should make a difference between vital and gnostic sensibility. So a very high quality sensory investigation is important. Not always a 2-point discrimination test, but be aware that subtle problems might not be seen. And soft tissue condition is very important, especially flexor zones 2 and extensor zones 1 to 5 are prone for problems in hand fractures. So look for these, and open fractures are very big problems. So additional imaging, always in case of malalignment, always in case of rotational deformity, and always in case of functional deficit of the hand, because this is the most important reason you would like to treat a hand fracture, because functional deficit of the hand is not tolerated. Standard 3 directions, anterior oblique and full lateral in most cases, especially for fingers, which is the normal way to image these fractures. So I told you before, CT imaging has become much more obvious. We do standard CT imaging for almost all intra-articular pre-op indications, especially specific fractures are very difficult to see on standard conventional X-ray. You can see a fracture dislocation of the base of the 5th metacarpal with a longitudinal fracture in the hamate. These kind of injuries are very difficult to see on standard X-view X-ray. So a low threshold for additional imaging in the form of CT imaging is always a good thing. So when we talk about fracture selection for operative treatment, we should realize that the majority of all hand fractures are actually functionally stable. And functionally stable means that they do not dislocate under influence of normal physiological powers in resting position. So the intrinsic and extrinsic muscles of the hand do not dislocate the fracture under normal circumstances in resting position. So that means that we only need to operate these fractures that are not functionally stable. So a few factors are responsible for the fact that fractures are not functionally stable and do dislocate and do have to be treated operatively. First of all, the location. Intra-articular fractures are a lot less tolerant for displacement. So that's a very important factor. Fracture geometry can be a factor that induces instability, especially oblique spiral fractures. In shortening, most of these fractures will rotate, and rotation will lead to a very large functional deficit. It's a nice example of a very subtle fracture of the mid-phalanx that leads to a very significant rotational deformity when the finger are flexed. Complicated fractures, because this is merely a wound with a fracture present, and these have high complication rates if not treated operatively. And associated soft tissue injury, I mentioned this before, especially the extensor zones 1 to 5 at the level from the distal phalanx into the MCP joints, and the flexor zones 2, where there is a tendon sheet. There's usually a big problem if there is associated soft tissue. So these need our specific attention. And multiple fractures can be a reason because the stability, the intrinsic stability of the adjacent finger is absent if there's a fracture as well. And some fracture patterns are intrinsically unstable, especially translation more than the half width of the shaft, shortening of more than 3-4 millimeters, and rotational deformity of 15 to 25 degrees are inherently intrinsic unstable. So these fractures do benefit from operative treatment. And if you do disregard these deforming forces of the intrinsic hand muscles, a Swanneck or boutonniere or pseudocloying can be the result of malalignment from these intrinsic and extrinsic muscles. So phalangeal fractures, 3 types: distal, middle, and proximal. That's quite easy. And the distal phalanx fracture is actually the most common fracture in the hand. As surgeons probably do not realize that because we hardly treat them operatively, but in the ER, this is the most presented fracture in the hand. There are 4 types: tuft fractures, shaft, articular, and complex fractures. Let's discuss the tuft fractures shortly. These are the result of crush injuries, and a significant amount of these are associated with nail bed injury. And if there is a subungual hematoma, this is a sign that there is a significant damage to the nail bed. So the underlying nail bed needs to be treated. And if the hematoma is less than 50% on average, you can evacuate the hematoma by drilling a hole in the nail plate. But if the hematoma is much more than 50% of the nail bed, often the nail plate needs to be removed, the nail bed needs to be repaired, and the plate needs to be reused again. So remember that the periosteum of the distal phalanx is adjacent to the nail bed. So when there is a nail bed injury, there is actually an open fracture. So this might lead to some problems. However, the majority, more than 95% of these fractures can be treated conservatively. And this is, according to the guideline, the way to go. This is actually the way we treat them in our clinic. A custom-made splint for 3 weeks with the DRP joint in 0 degrees flexion. There is rarely or hardly ever any indication for internal fixation, mainly due to the fact that the fracture fragments do unite fibrously. So shaft fractures, some general considerations, especially the closed exarticular fractures, should be treated conservatively. Again, in a custom-made splint, 0 degrees flexion in the DRP joint. Do keep the PRP joint free because you don't want to immobilize that. And immobilization can be done quite shortly because if there is if the fracture is distal from the insertion of the flexor digitorum profundus and distal from the extensor digitorum, then a secondary dislocation is quite uncommon, and functional exercise can be started already as briefly as 1 week after injury. So these fractures can be mobilized quite early on. Well, shaft fractures, different types, transverse, quite rare, transverse and longitudinal, quite rare. And surgery is actually only done for severely displaced fractures, usually combined by a nail bed injury, and then the nail bed injury should be repaired. Special mention for Seymour fractures. This is a fracture in childhood through the physis of the distal phalanx, and due to the deforming forces of the flexor digitorum profundus on the volar side and extensor on the dorsal side, there is a dorsal apex dislocation, which usually is present already at first clinical presentation. So these fractures need to be reduced closely, and then the nail plate needs to be reduced and nail foot needs to be closed, like you can see here. Don't miss these fractures. For distal phalanx fractures, again, non-union occurs sporadically. We do operate them if there's a significant dislocation and an unstable configuration. This is a nice example, complete shaft with dislocation with a very unstable configuration due to the very severe translation of this fracture. K-wires are the tool to do this, and you should remove them quite early on. After 3 weeks is long enough. Here's this case, severely displaced distal phalanx fracture with a more than 1 shaft width of dislocation, severe soft tissue damage. This was reduced using a transarticular K-wire. This K-wire was removed after 3 weeks. The nail bed was repaired, and functional outcome was quite acceptable. Here's another example. This is a quite unconventional way to treat these kind of fractures, but there's also a role for cannulated screws. This is a antegrade inserted cannulated screw, and the advantage is that early mobilization and fast functional outcome can be achieved here. It's not always very easy. Persistent dorsal angulation of the distal phalanx can be the result. Nail bed damage and iatrogenic fractures of the tuft can be the result of malpositioning of the screw. And as you can see, there's not a lot of margin for placing these kind of screws in the phalanx, but for some indications, I like doing this. Special mention for the mallet type fractures. We see them a lot, and there's a lot of discussion about the largeness or how large or how small should the avulsion fragment be. If you look at the guideline, less than 30 to 40% of this avulsion fragment and absence of volar subluxation of the distal phalanx is an indication to treat them conservatively. Now, it can be quite difficult to judge whether there's a volar subluxation, so always make an X-ray in extension. This is the same patient in which the end phalanx, the DRP joint, was immobilized in full extension, even in a little bit hyperextension. And you can see that there's no volar subluxation. So do make an X-ray in extension, which makes the decision to treat them conservatively a lot easier. So this fracture did not present with a volar subluxation. So this was treated in a custom-made DRP joint brace, 6 to 8 weeks minimum, and gradual reduction after 6 to 8 weeks. You can see the end result after 6 weeks here. It's a nice congruent joint with a reduced fragment, and this fragment has already healed. Functional outcome is quite good, but it can take a while before functional outcome can be reached. So when do we have to operate these? If the avulsion fragment is large enough, I never measure it, but if there is also a volar subluxation, you have to operate them. You can see a nice example of, again, the X-ray and extension of the DRP joint, and now you can see a clear volar subluxation of the distal phalanx. So we use the Ishiguro technique, extension block pinning. This can be done percutaneously, and these KYs should be removed after 6 weeks. Here's the end result after 6 weeks. KYs were removed. Functional outcome was quite acceptable. Another case, another mention for the volar type of avulsion injuries is the Jersey finger. Usually it's the ring finger, but all fingers can be the result of this injury. And this is an avulsion injury of the insertion of the flexor digitorum profundus at the base of the distal phalanx. There are 3 types. Type 1, there is the flexor tendon is retracted into the palm. This is quite rare. We hardly ever see them. Type 2, the FDP lies at the level of the PIP joint, and type 3, which is a true avulsion fracture in which the fragment can actually be quite large. Then the tendon rests at usually the distal part of the A4 pulley due to the fact that there is a osseous fragment that prohibits further dislocation. So always operative treatment of these and permit functional after treatment if possible. So these type 3 are the ones we see the most, and you have to reduce the avulsion fragment and stable fixated into the end phalanx. So here's a nice situation. This is actually not only Jersey finger, but also Mallet finger. This is quite rare. I had one, I think, 2 or 3 years ago, and you can see a severe dislocation of the base of the distal phalanx where the insertion of the FDP is on the volar side, and a severe dislocation of the fragment on the dorsal side where the terminal extensor slip inserts. So this was a combined procedure of a Ishiguro extension block pinning and a reinsertion with a quite large volar screw to reinsert, a bone anchor to reinsert the flexor digitorum profundus, and this patient was permitted functional after treatment after 6 to 8 weeks, and functional outcome was quite good. Here's another example. We operated this one quite recently. This is an avulsion of the FTP joint from the distal phalanx with a very large fragment. And again, we used a K-wire blocking type, but now it's a flexion blocking type of a fixation in which the fragment was reduced closely, and with this flexion block type of K-wires, this was reduced. So let's go a little bit more proximal, middle and proximal phalanx fractures. Again, most of these are non-displaced and stable. And you have to realize that stiffness and deformity comes from improper treatment of unstable fractures. We already mentioned that. Deformity, especially from the dislocating forces of the intrinsic and extrinsics. Stiffness, especially from over-treating these ones with a lot of large incisions and a lot of adhesion formation. And there are several factors that influence bad outcome from these fractures. Advanced age is very important. Restored mobility is at the highest level in the first 2 decades of your life. If you look at all hand fractures, there's been a nice study, I think it was 10 years ago, then hand mobility is rejoined again in 88% of cases in the first 2 decades of life. And that up to the 6th or 7th decade of life, this is only the case in up to 60% of cases. So advanced age comes with inferior outcome. Associated arthritis, obviously, because this is an influence of advanced age. Now, articular involvement is very important for fractures, but due to the fact that hands are not the subject of very heavy load, stability and alignment is usually more important than articular involvement. Comminution and the result of that is bone loss can be a very big problem. And soft tissue injuries, again, especially in extensor and flexor zones, can be a big problem. uncooperative and non-compliant patients should be protected from extensive surgery because they might propose themselves with a big problem. So middle phalanx fractures can be treated conservatively. Actually, the majority of these are treated conservatively. So stable closed extra-articular fractures should be treated conservatively. This is the preferred treatment, 3 weeks in an extension splint with the PRP and the DRP joint in 0 degrees. So this is an aluminum splint. In my practice, I use a lot of thermoplast splints, but both are options. Both are quite excellent to do the job. This is an alternative, functional splinting, a body type of splint. However, these do not always offer the amount of stability you want, but for a lot of non-displaced fractures, this can be an option. So in the guidelines, it's mentioned that a significant number of these fractures do dislocate due to the pull of the central slip or to the pull of the superficial flexor tendon, and this depends on the location of the fracture. So the proximal part of the middle phalanx, if the fracture is there, there's usually an apex dorsal angulation, and if the fracture is in the distal part of the middle phalanx, there might be a volar apex dislocation. So do realize that this might happen and do an X-ray checkup after 1 week for especially the transverse type of fractures. So when should we operate these? When we are unable to maintain alignment, when these are immobilized, as I have shown you, and if there's significant dislocation. And for the middle phalanx, significant dislocation is indicated when there is less than 50% bony contact. Significant angulation, the more distal you get, the more obvious the angulation will get and the more functional problems it will give you. So for the middle phalanx, more than 10 to 15 degrees of angulation is considered significant, and also shortening more than 2 to 3 millimeters. And the rotational deformity is the most important factor that influences functional outcome negatively. So we do not tolerate any rotational deformity. And 5 degrees of rotation already gives you 15 millimeters of overlapping of the fingers. So scissoring of the fingers can be a quite early result of rotational deformity. I already mentioned this one. And again, scissoring of the fingers with a limited amount of rotational deformity needed for that is a very large functional limitation. So a special mention for PRP joint injuries. I could discuss these for hours and hours, but I would like to highlight a few things that are important because this is a frequently seen injury and still gives a lot of discussion. I've seen some recent cases on LinkedIn of these, and I would like to point out a few things that are important. So different types. There's your dorsal PRP dislocation, which is a quite common one. A volar PRP dislocation, which is a little bit less common, and a lateral DRP dislocation, which is quite uncommon. So from very common to very uncommon. And usually they're combined with fractures, and then we are talking about PRP dislocation fractures. So a dorsal PRP dislocation is quite common, and there are 3 types. These are the injuries that present after we reduce them, and there are 3 types. Type 1 is a completely congruent joint with any absence of dislocation. Type 2, there is a subluxation in the PRP joint to dorsally. This is called a bayonet dislocation. And type 3, there's an aversion type of fracture from the volar side. So closed reduction and functional treatment is the way to treat these fractures, these dislocations. And you should test stability and function after reduction by active and passively testing the function of the PRP joint in flexion and extension, like you can see here. If you make an X-ray after reduction, be sure that you look for a congruent joint. And a sign of incongruency is a V sign. You can see a nice V sign here dorsally. That means that the joint is not congruent and operative fixation should be considered. So when should these be operated on? Obviously, if no closed anatomical reduction is possible. And usually the reason is interposition or tendon luxation, which also causes functional limitation after reduction. Another reason is immediate redislocation after testing. If you do test them like you see in the pictures in the top of your screen, then there is an indication for operative treatment. And if you need more than 30 degrees of flexion in the PRP joint to maintain joint congruency or stability. So if you have to prevent dislocation by not extending more than 30 degrees in the PRP joint, then you have to consider operative treatment. So when you treat them conservatively, this is a nice way to treat them. This is a very easy extension block splint type, a maximum of 30 degrees flexion, as I told you. You fix this to the wrist with a tape or with Velcro tape, like you can see here, and then flexion is permitted and extension is blocked at 20 to 30 degrees of extension. So if you do not succeed to redislocate these, then operative treatment is usually indicated. And this is a fairly nice technique I like a lot. This is a sort of a Suzuki traction. This is a ligamented taxo, which is a quite easy applicable dynamic traction, very suited for PRP injuries. And the patient is allowed to functionally treat this finger immediately after surgery. So this is one of the options, a very nice option I like a lot. So a volar PRP dislocation is a little bit more uncommon and is usually associated with central slip lesions. So there are quite a few different types. A simple one, which is a non-rotational lesion in which both condyles are usually perforating the central slip, or a rotational PRP dislocation when one condyle is usually injuring it. And there is often a central slip lesion, so look for that. So the continuity of the extensor tendon must be examined. And you do that like you can see here. This is a test in which you can test the central slip, whether it's present or not, and whether it's functioning or not. So if there's a central slip lesion, the PRP should be immobilized in 0 degrees. Indication for operative treatment, again, if no closed anatomical reduction is possible, if you have persistent functional limitation after reduction, usually due to in the position of capsule or tendon luxation, and if the joint redislocates immediately after testing, then it's a completely unstable joint. So these are indications for operative treatment. So a special mention for PRP dislocation fractures, and especially the dorsal PRP dislocation fractures. So this is a famous summary of these fractures, and there are 3 types actually, in which there's a stable PRP injury after reduction, in which there's an unstable if there's a very large volar fragment, and if these are stable in maximum 30 degrees of flexion, these are tenuously stable. So they might redislocate and might be an indication for surgery. The unstable ones are always indication for surgery. So when do we treat them operatively? What are the ways to treat these operatively? There's several ways to do this. One of these is the open reposition and internal fixation of the volar fragment, but this can be quite difficult because usually these are very small fragments, so you need very small screws. I will show a few examples later on. Another option is a volar plate reconstruction, especially if the fragment is very small and there's a volar plate damaging due to these injuries. And another option is a hemi-hamate. I've done all three in cadavers. I've never done large numbers in patients, in actual patients. And I think I know a few colleagues who do, and functional outcome is not always excellent. So if you're able to do it, I think it's a very cool tool to use, but functional outcome can be quite disappointing. So this is a nice technique if there's a very small avulsion with a volar plate avulsion from the mid-phalanx. As you can see on the second X-ray, closed reduction was not possible and there was persistent deposition. There's a very small fragment. It's difficult to see, but there's a very small avulsion fragment attached to the volar plate. So we used a very small bone anchor. This was radiolucent, so you cannot actually see it on the X-ray, but the volar plate was reintroduced into the base of the mid-phalanx using this small bone anchor. The joint is congruent again, but there can be some shortening of the volar plate post-operatively, especially on the midterm, so you need extensive hand therapy post-operatively. And on the right, you can see the X-ray after 6 weeks, in which there is actually sort of a adhesion formation at the volar side of the volar plate. So PRP dislocation fractures also present with a volar PRP dislocation. They are very rare, and these present with a discontinuity of the central slip insertion. So again, operative treatment is indication in which, if there is persistent subluxation, redislocation extension, and if there's a displaced large dorsal fragment, usually more than 30%. Now, this is a very nice case of a displaced large dorsal fragment. I operated, I think, 2 years ago, and there's also a diaphyseal and metaphyseal component to this. And if you look closely, you can see a persistent subluxation in the PRP joint with a volar displacement of the mid-phalanx. So I reduced this open, and I used 1.2 screws to reconstruct the PRP joint. And there was a nice anatomical situation post-operatively. A little bit of extension deficit in the PRP joint, but the long-term functional outcome was quite good for this patient. So let's go a little bit more proximal then. We've left the PRP joint. Let's go to the proximal phalanx. Again, there's a big role for non-operative treatment, and this should be considered if there's no significant dislocation, no shortening or rotational deformity, no significant angulation, and sometimes if there is no comminution or multiple fractures. And you can treat these fractures non-operatively if they are fit for functional treatment, so if they are functionally stable. And this is a nice way to treat them. We have introduced this, I think, 2 to 3 years ago, in which we tried to treat most of these fractures in a functional way. This is called a Lutz cast. I can show you how it works. Sorry for the sound, but you can see that the patient is able to actively extend and flex the fingers, and there's a cap on the dorsal side which prevents from hyperextension, extension of more than 30 degrees in the PRP joint and MCP joint. So this is a very nice way to treat these fractures functionally. So operative treatment for these fractures should be considered when there's significant dislocation, especially if there's more than half the width of the shaft dislocation. Again, shortening or rotational deformity, and especially oblique fractures and spiral fracture do give a rotational deformity if they shorten. Angulation more than 25 degrees, and comminution or multiple fractures. Again, the adjacent ray is responsible for giving additional stability. So if there's a fracture there as well, there's additional instability. And some fractures are not fit for functional treatment, and they do dislocate in an early stage. Again, it is advised to do an early X-ray checkup, because the insertion of the extensor slip, the central slip, and the superficial tendon, flexor tendon, can cause especially a volar apex dislocation or dorsally directed dislocation of these fractures. And open fractures should be treated operatively as well. So persistent angulation is a big problem and can lead to significant functional problems due to the fact that swan neck and pseudochlorine can be the result of the deforming forces of the hand muscles. So when we discuss surgical techniques or surgery for proximal and middle phalanx, there are 3 basic rules when we use surgical techniques. And these are the 3, I think, sacred rules when operating hand fractures. Try to do it closed or percutaneously if possible to minimize soft tissue damage and adhesion formation. Secondly is limit the amount of material. So try to reach the maximum result with the minimum amount of material. If you can do the same with less material, try to do that. And last but not least, try to treat every fracture in a way that is functionally stable immediately post-operative. So no prolonged post-operative immobilization like you've seen in the second or the third slide I showed you. So what are our options? Obviously closed reduction, which is the way to go if that is possible, and open reduction if a closed reduction is not possible. So closed reduction, percutaneous pinning, not always as easy as it looks. Percutaneous screw fixation, not always as easy as it looks. And static or dynamic external fixation, not only for PRP joint injuries, but also for fractures, and especially for proximal phalanx fractures. Comminuted types, dynamic external fixation is a nice option to consider. Then open reduction, also pin and KY fixation, screw fixation after open reduction, and plate fixation, which is the most stable construction there is. And intramedullary fixation is also an option, not only in the distal phalanx, but also in the proximal and middle phalanx, and obviously in the metacarpal. So when we discuss close reduction and percutaneous pinning, we should realize that early motion is possible due to stabilization of the fracture. And you would like to do that because it will lead to minimization of soft tissue injury. However, it's not suited for all type of fracture, and especially comminuted fractures are not suited for percutaneous fixation using K-wires. And there are several pin configurations possible. Retrograde cross pinning is an option, and I will show you a few cases. Anterograde cross pinning is also an option, which is the most used method of fixing percutaneously with K-wires. Single anterograde intramedullary pin is an option. I really do not like this technique, but it usually means that you have to immobilize the PRP or MCP joint, which prevents early joint mobility and increases tendon and joint adhesion. So I don't really like that. And the last technique that is sometimes proposed in books is perpendicular to the fracture. And again, this does counteract with early functional after treatment, because you do immobilize the extensor hood when you use these techniques. It is impossible to maintain complete joint mobility and tendon gliding if you use this technique to fix a fracture. So a few examples of an anterograde cross pinning. This was placed percutaneously after close reduction, and joint mobility was preserved by not fixing the joint like this. This is an example of a retrograde cross pinning. And you can see a pitfall here where the K-wires are crossing in the fracture, which leads to rotational deformity due to the fact that this does not deliver enough rotational stability. So again, it looks like an easy technique, but it's not always as easy as it looks. This is an example of a single anterograde intramedullary pin. It's called the Eaton-Belsky technique, in which a single 1.6 K-wire was used to stabilize this proximal phalangeal fracture in an anatomical way. But as I told you, the MCP joint was partially immobilized due to the fact that the K-wire blocked it. So another way, obviously, is open reduction and internal fixation. And you can also use K-wires after open reduction. Again, by using K-wires, you get minimal soft tissue stirping, and it is less bulky than plate and screws. So you maintain blood flow, and it's suited for many types of fracture, but there are limits to this technique. I think the fracture you can see here is maybe not the best indication for this technique. So distraction and loss of compression can be the result. I've showed you this case before, retrograde cross pinning, where the K-wires are crossing in the fracture, and an unstable configuration is the result. And again, not suited for comminuted and open fractures. And this is an option that is often propagated, tension band wiring. Personally, I don't like it because you might interfere with periosteal blood flow, and I think there's a limited amount of indications for this technique. So after open reduction, obviously screw fixation is also an option, and you get stability through interfragmentary compression. So you need to use these as lag screws that provide you with a high degree of interfragmentary compression. And the result is immediate functional rehabilitation and less interference with the extensor apparatus, less interference than K-wires, and less interference than plate and screws. And as a result, there's no need for standard hardware removal. So that's a very positive outcome as well. If you look at literature, and the guideline looked at 6 or 7 studies that compared screws to K-wires and plates, then stiffness and complications is similar to K-wires, but functional outcome on mid and long term is significantly better than plate and screws. So if you do have an option to use single screw configurations like this as lag screws, do use it and prefer it over plate and screws. It can be quite technically demanding because the screw has to be perpendicular to the fracture, and especially in long spiral fractures, this can be a very technically demanding procedure. A few examples: a proximal phalangeal fracture of the small and ring finger with a lot of comminution in the ring finger especially. So this was reduced open, and these 1.2 screws were used as fixation technique. Immediate functional treatment is possible, and usually if you let patients functionally exercise immediately, then outcome is better. Then last but not least, open reduction and plate fixation. So this is the most stable construct, and again is very suited for early controlled motion. There are, however, more complications, and especially extensor tightness. Extrinsic extensor tightness is a fairly common complication of this technique, especially when using a dorsal approach and a tendon splitting approach. So you can see that there is diminished flexion in the PRP joint when the MCP joint is flexed as well, and there's a little bit increased flexion if the MCP joint is extended. So the extensor is too short here, so this is extrinsic extensor tightness due to the surgical procedure. Tendon release, lengthening, or tenolysis is an option. And usually you get immediate, very good results perioperatively, but again, stiffness after the procedure has been performed in the long term can be the result, especially if intensive hand therapy is not being done. So lateral application leads to less stiffness due to the fact that there's less interference with the extensor mechanism, but still this is a technique that leads to adhesion formation and stiffness as well. And a big advantage in the last 3 years is that there are a lot of thinner plates on the market that lead to less interference with extensor excursion. So these plates do help us to reduce the amount of extensor stiffness after procedures. Few examples: proximal phalangeal fracture in a rotational deformation, open reduction, and a lateral plate application was done after a mid-axial approach of this joint and the proximal phalanx. Another example of a proximal phalangeal fracture with a short comminution zone in the middle. A bridging plate technique was used with a somewhat older plate. This is a little bit thicker plate, but outcome was quite good. Then a proximal phalangeal fracture with a rotational deformity. A lag screw was used here, and then a neutralization plate was placed to neutralize the forces over this lag screw. And anatomical reconstruction was quite nice. There are two phalangeal fractures of the proximal phalanx of the ring finger and the middle finger, and this is an intrinsic unstable fracture pattern due to the absence of the stabilization of the adjacent finger, because there's a fracture there, periarticular fracture as well. And this was being treated from a dorsal applicated T-plate. This is the latest generation plates. These are a lot smaller, a lot thinner, and do lead to less interference with the extensor tendons. So a small trick when you do an open reduction internal fixation, it can be quite technically demanding to reduce these fractures and put on the plate in a proper fashion. So a nice trick is to stabilize and realign these fractures using a single K-wire or even 2 K-wires, and then fix the plate using unicortical screw, one unicortical screw at both sides, then remove the K-wire and fix the rest of the plate as you are used to doing. So this is a fairly easy technique which provides you with a nice way of stabilizing the fracture before the plate is applicated. So last but not least is external fixation. It's quite uncommon in hand fractures, but sometimes there's severe tissue damage, and then external fixation is a very nice option, especially if there's significant loss of bone stock and comminution. This can be a fairly nice technique. So it's the ease of insertion and the absence of dissection that is the advantages of this technique. You do not devascularize the fracture, and you preserve bony length and still have access for soft tissue care, especially in severe open fractures. There's a nice case of a open fracture of the proximal phalanx of the small finger with an open wound there. This is an external fixator that was placed, and the nice thing is that this is a non-joint bridging external fixator, so functional treatment is still possible despite of the fact that these pins do somewhat violate the extensor tendon mechanism, but functional treatment is possible after surgery because you do not bridge the MCP and PRP joint. And here's the X-ray post-operatively that shows you quite nice alignment of this fracture. I told you before, I do like dynamic external fixation, so I also used the technique for comminuted fractures of the PRP joint, in which I like to reduce this fracture in a closed fashion. So this fracture was actually reduced in a closed way, and the ligamental taxer was applied, after which the fracture nicely realigned in a proper fashion, and functional treatment is possible immediately post-operatively. So this frame is removed at 6 to 8 weeks, and you need to check up X-ray at a few time intervals to make sure that the alignment is correct. And you can actually adjust the tension on the frame by just adjusting the springs. And by that, there's a very controlled way of letting this fracture heal in a perfect alignment. So the last part of my talk will be about metacarpal fractures, the same principles, but a few things I like to discuss. So there are a few types of metacarpal fractures: metacarpal head fractures, not so common; metacarpal neck fractures, very common; metacarpal shaft fractures, and metacarpal base fractures, which are usually fracture dislocations. So the head fractures are quite uncommon and can be challenging injuries. They're often comminuted and due to the fact that the joint surface of the head of the metacarpal is quite large, osteochondral lesions are quite common and do impose it with big problems. So if the joint is discongruent, you need to operate these. And countersunk screws is an option. A condylar plate or K-wires is also an option. Be aware of open fractures. And again, I would like to remind you of a very specific type of fractures we do sometimes see in our hospital, the so-called fight bite, in which the extensor tendon, the joint capsule, and the metacarpal head, and often the proximal phalanx, is damaged by the tooth of the opponent of the patient. So be aware that there's a high degree of tendon lacerations, a high degree of possible joint lacerations, with a high degree of infection as a consequence. So these need to be treated properly and be aware of severe complications. So the metacarpal neck fracture, to start, is the most common metacarpal fracture. Actually, in 70 to 90% of all metacarpal fractures, it is the small finger metacarpal. And we all do know the famous trauma mechanism that these fractures do present themselves with, and it's always this mechanism, never a fall on an outstretched hand, as most patients tell you. So when you look at all 37 studies that are the base for the Dutch guideline, the only studies that do present us with solid level 2 evidence are the studies on non-operative treatment of metacarpal neck fractures of the small finger when angulation is less than 70%. Under all circumstances, functional outcome is better if these fractures are treated non-operatively. So never treat a metacarpal neck fracture with an angulation less than 70 degrees operatively. You don't need to reduce them because this will not influence functional outcome. Do warn your patients that there might be a different side of the metacarpal neck. So from an appearance point of view, it might look a little bit aesthetically, it might look different, but there's no influence on functional outcome. So we do treat these early functional. We do give them a pressure bandage for maximum 48 hours. Then functional treatment is possible. The patients come back with persistent pain. We could consider a cast for 2 to 3 weeks maximum, but we like to treat all these fractures functional as early as possible. So operative treatment can be considered when angulation is more than 70 degrees. I've shown you this case before, and try to do that minimal invasive as possible. This is one way of treating these, in which these K-wires are introduced from lateral in a minimal invasive way. This is another option, antegrade intermedullary K-wires. This is called so-called Bouquet pinning technique, fairly nice technique. It's not always very easy. And for both, and especially for the Bouquet pinning technique, functional treatment is possible. So when we go more proximally, remember that the same angulation of the fracture more proximal into the shaft leads to more shortening. So as a result, there is less tolerance for angulation in the shaft than in the metacarpal neck. So if there is more angulation, there's usually more shortening, and more shortening leads in a lot of cases to rotational deformity. So when alignment and rotation are not normal, you need to operatively treat these fractures. So when they are normal, conservative treatment is an option. Don't reduce these fractures if they are minimally dislocated, and do not present with functional limitations because it doesn't make any sense. So which one do we treat operatively? If they are dislocated and present with functional limitation, open fractures obviously, multiple fractures again, because these are inherently unstable fracture configurations, and again, minimally invasive if possible. As a nice example, this is a dislocated fracture with a functional limitation due to a rotational deformity. You can see it in this picture. So we treated this fracture with two 2.0 screws perpendicular to the fracture. You might argue that these screws are quite close to one another, but they do the trick nicely, and these two lag screws reduce the fracture in an anatomical way, and functional treatment is possible. Here's another example of multiple fractures. There's a shaft fracture of the ring finger metacarpal, and as you can see, there's also a shaft fracture of the small finger metacarpal. And some people might have noticed that there's also a Aversion type of fracture on the radial side of the base of the small finger metacarpal. So this is a patient that was with us before for reverse Bennett fracture in the past. So a lot of these patients do come back with these kind of injuries. So these transverse fractures are perfectly suitable for intramedullary K-wire pinning, antegrade intramedullary pinning. And I use 1.2 millimeter K-wires or even smaller for that technique. So we did one recently, and I would like to show you how this technique works. You approach the fracture in a minimal invasive way, so small 2 to 3 millimeter incision, in which you place your drill guide and then open the medullary canal from the base of the small finger metacarpal using a 1.8 or 2.0 drill. Then pre-bend your K-wire and advance this K-wire through the hole of the drill guide. That makes advancement of this K-wire quite easily. Sometimes you need to hammer it in and get it in the perfect position in the head of the metacarpal. After you have stabilized one ray, usually the most dislocated is the first one to reduce and fixed. Then the second ray is being fixed using the same technique. This is the perioperative situation. And on the right side, you can see the post-operative situation at 6 weeks with nice bridging callus. K-wires can be removed at the outpatient clinic at 6 to 8 weeks. And immediate functional treatment is possible with this technique. And most patients do have an excellent hand function within 2 to 3 weeks due to the fact that they can immediately move their hand and flex their fingers after they have been operated using this technique. So if it's possible, and if the fracture is suitable for this, especially transverse fractures that are severely dislocated, this is a very nice technique to consider. So another indication for operation is multiple fractures. This was a patient that had a crush injury of his hands at a working incident with a fracture of the shaft of the small finger metacarpal, ring finger metacarpal, the subcapital fracture of the middle finger metacarpal. There was a wound that had to be debrided. There was an extensive tendon damage. So we used an open approach, obviously, and did a fixation of this technique with 3 bridging plates over all metacarpals. And again, due to the fact that this is a very stable construct, immediate functional treatment is possible. So let's go more proximal again to the metacarpal base fractures. There's 2 types, the extraarticular and the intraarticular. So the extraarticular is very rare, usually minimal displaced, and there's an adjacent CMC luxation possible. I couldn't find any case from my own library, so I had to take a Google picture. I'm sorry for that, but I've never operated an extraarticular metacarpal base fracture in my collection, so I couldn't find any. So intraarticular are much more common. Usually it's a small ring finger metacarpal, and the adjacent ray, the adjacent metacarpal, usually shows a dislocation in the carpal metacarpal joint. So look out for that, and do ask for lateral X-rays if they're not visible on the 3/4 and AP view. And again, CT scan can be quite helpful for these kind of injuries. Here's a nice example of a small finger metacarpal base fracture. You can see that there's a dislocation of the base of the metacarpal from the hamate, and the radial part is at its original location. So this is a reverse Bennett. close reduction, and percutaneous K-wire. These K-wires can be removed at 6 to 8 weeks, and functional treatment is possible quite early on. This is another example. This is a base metacarpal fracture of the ring finger metacarpal, but again, a dislocation in the small finger metacarpal. So we reduced and fixed the base metacarpal fracture from the ring finger using this T-plate, and reduced the small finger metacarpal into the hamate by using 1 K-wire. You could argue using a second K-wire into the base of the fourth metacarpal, but we gain stability like this. Then a special mention for the metacarpal-based fracture dislocations. These are quite troublesome to see on standard X-rays. 1 second, I'm sorry. So you can see a dislocated small finger metacarpal fracture here. And there was some doubt about the congruity of the hamate. And as you can see on the CT scan of this patient, there was a quite large fragment of the hamate that was the reason for the dislocation of the small finger metacarpal. So we reduced the fragment, used a screw to reduce and fix the fragment, and then used a 2.0 bridging plate to reduce the metacarpal base again. Now this plate can be removed at 8 to 10 weeks. And again, functional treatment is possible. If you leave this plate inside, there's a big chance that the plate will break from itself. That is no big problem, but a broken plate and extensor tendons are not very good friends. So you should consider removing this plate at an early stage, as early as 8 to 10 weeks post-operatively. Here's another example. Now this is the quite typical patient that present with a base fracture of the ring finger and a dislocation of the small finger metacarpal. And as you can see, I'm sorry, there was already a fracture in the past. So this is the typical patient we do see a lot with hand fractures. And again, we made a CT scan, and you can see a very specific injury in which there is a longitudinal fracture of the ring finger metacarpal with a fracture of the hamate, which dorsally dislocated, and a dislocation of the small finger metacarpal as well, with the same large fragment of the hamate. So again, this fragment was reduced in the hamate, after which we used a bridging plate over the fourth carpal metacarpal joint, and last but not least, we reduced the small finger metacarpal. Here's your post-operative situation. So that brings me to the end. And my voice is abandoning me, so the timing is quite good. So my take-home message is: fracture and patient-related fractures are essential for the decision to operate or not. Functional limitation or expected functional limitation is the most important indication for surgery. Treatment should enable direct functional rehabilitation if it is anyway possible. Maximum result with minimum material, and percutaneous or minimal invasive is, if possible, is the way to go. Thank you very much.